All right, good morning. Well, welcome everybody. We are excited to participate in this important CTSNet Edwards webinar, looking at the lifetime management of patients with aortic valve disease. And I have the privilege to be joined by several colleagues and very good friends who will discuss this important topic. My name is Tom Nguyen. I'm the Chief of Cardiothoracic Surgery at UCSF in San Francisco. Doug Johnson will briefly make a virtual appearance and give a talk. Doug is the Vice Chair of the Department of Thoracic and Cardiovascular Surgery at the Cleveland Clinic. Dr. Bart Meuris is the Chief of Cardiovascular Surgery in Belgium, and then Dr. Ed Soltesz has also very graciously joined. He's the Surgical Director of Heart Failure at the Cleveland Clinic. We're going to discuss how to manage patients with aortic valve disease and think long-term. And I think a lot of times when people think about aortic valve disease, we're kind of thinking how to get this patient through that severe AS. But I think it's so important to kind of look into the future and try to figure out what's best for the patient long-term. And that's going to be the focus of our discussion today. Briefly, we'll start off with a talk by myself, and I'll talk about the lifetime management of aortic valve disease and how I approach patients with severe AS. Dr. Johnson will give his experience from the Cleveland Clinic with the use of tissue valves. Dr. Bart Meuris will provide some health economic data for Inspiris Resilia tissue valve, a new technology for aortic valve disease. And most of it we'll have a discussion and kind of bring up important questions and topics. I encourage everybody to use the chat box and enter your questions, and we'll do our best to try to answer the questions. At the end of the webinar, we'll provide our contact information. If you want to contact us personally with questions, please do. So without further ado, I'll go ahead and get started. These are our disclosures. This is the framework of the discussion this morning that I briefly described. Again, thank you, the panelists, for joining, and thank you all the attendees for joining us this morning. My title is Lifetime Management, My Views on a Dramatic Shift in Valve Selection in 2022. These are my disclosures. I want to start off with a scenario. You have a 6-year-old man with newly diagnosed aortic stenosis. And one thing I always ask my team is, tell me the left ventricular outflow tract size, because that gives me an idea of whether or not I'm going to have to do kind of a little bit bigger operation or if it's going to be an easy operation. So for this patient, his LVOT is 23 millimeters. As a background, he received an executive physical and he complained of fatigue and underwent a TTE. His past medical history is significant for hypertension that was unmanaged. His creatinine is slightly elevated, his BNP is greater than 500. So when you think about this patient, you really have three kind of buckets of really what to do. I think most probably wouldn't do a TAVR in this situation, but you would decide whether or not you want to do a surgical valve, you want to do a rapid deployment valve, or a mechanical valve. And here are the options, as you can see here on the screen. But we know there are pros and cons of tissue versus mechanical valves. And these are numbers that we often quote. For a biological valve, we know that there's a higher risk for redo operation. And it's almost 13 times higher risk of reoperation for a biological valve versus a mechanical valve. A mechanical valve has a high risk of bleeding, 8.5 versus 2.2%, almost 4 times as risk. So that's important to consider as we try to balance tissue versus mechanical valve. But that said, this slide by Dr. Meuris presented at AATS, and I think he's going to elaborate on this slide a little bit, but it's pretty clear that we're seeing an increased use of tissue valves, not only here in the United States, but across the globe. And the question is why so? And this is my kind of thought why people are choosing more biological valves. One, I think it's pretty clear patients don't want Coumadin, and I think it's more than just taking Coumadin. I think it's the lifestyle changes of needing to take Coumadin, the INR checks, the avoiding green leafy vegetables, as well as the risk of bleeding. I think people want biological valves because TAVR valve-in-valve technology is promising, it is improving. And I think we need to a certain extent respect that as a potential modality. And I do think that technology has changed, and I think we are seeing some great advances in tissue technologies for biological valves, and they are improving. And some of the preliminary results from the CONVENT trial are actually really, really exciting, and hopefully they'll continue to trend in that direction. So I've never had a patient come to my office begging me for Coumadin. It just doesn't really happen. So in that respect, I see myself actually implanting more tissue valves and mechanical these days as well. So in this patient that we just described, my approach is a minimally invasive aortic valve replacement. probably 90% of my isolated AVRs and even a good percentage of concomitant valves are done minimally invasively. And I'll kind of expand on that in a little bit later. And I want to kind of talk a little bit about my techniques for minimally invasive aortic valve replacement. A lot of times people ask, where do I do my incision location? It's pretty straightforward. I don't count ribs or any of that sort of stuff. I mark the subcostal margin, and this is a coronal view, and you can see the aortic valve is there. And I think the temptation is to try to make the cross clamp low and try to make your incision low so you're close to the aortic valve. And I think that's kind of the wrong way to do it. And the reason why is because if you do that, you actually end up looking at the aortic valve kind of off axis at a cant. So my approach is to try to get that cross clamp as high as possible, dissect right above the right PA, drag the aorta down, get that cross clamp as high as possible. But even your incision location, I think, should be a little bit higher than usual. So you can look down at the aortic valve at a barrel, so you get a very kind of direct en face view of the aortic valve. So that's kind of my approach. I have to admit, when I first started my minimally invasive program, I made that error of making the incision a little bit too close and not getting as direct view of the aortic valve, and then making it a little bit higher and getting a direct en face view. So this is a patient's a picture of a patient. The red circle represents the aortic valve roughly, and you'll see here my incision location is roughly right there, and that will give a very excellent view. I also want to add that people often ask, like, why do you do a right thoracotomy, and what are the advantages of right thoracotomy versus sternotomy? As you see from the left panel, the aortic valve actually points towards your right chest, and even if you're doing a sternotomy right down the middle, oftentimes you have to twist the heart a little bit just to be able to see the valve. But if you make an incision in the right chest, to me, my bias is you get a potential more direct view of the aortic valve. So that's kind of my preference of doing right chest surgery, especially for aortic valve disease. Even for obese patients or women with large breasts, or even breast implants, that doesn't provide any reservation for me to do a minimally invasive approach, and we do it fairly frequently. I want to talk a little bit about cannulation approaches. This is us for the cannulation. I think we always talk about cannulation. It's really easy, but I think this is where you can really end up causing some complications and some issues. I usually cannula the left groin, and the reason why I do that is because cardiology will often do a cath on the right groin, and sometimes, and most of the times, there's some kind of hematoma and whatnot. So I just kind of avoid that altogether, but also recognizing that it's easier to get to advance a cannula, a venous cannula through the right groin if necessary. I expose the femoral artery, femoral vein, as you saw. I don't circumferentially expose it. I take the venous cannula, I put it on top of the patient's body before I introduce it, and this gives me an idea of how deep to advance that cannula. I'm obviously going to be using echo guidance as well, but that kind of gives me a rough idea of whether I should push it up to like maybe 50 or 60 centimeters. Really important to make sure the wire is in the SVC. During my first experiences, I wasn't so clear about that, and it's very easy to cause either a right atrial or RV perforation if it's not in the SVC. I'll secure the cannulas. And probably a little bit less so on the venous side. The venous side is a little bit unlikely to dislodge as much as arterial. I'll connect it to the bypass circuit. I'll access the femoral artery. I'll ask anesthesia to give me a short axis view of the descending aorta, make sure that wire is in the descending aorta. I'll advance the arterial cannula. And something I want to say about the arterial cannula is that perfusion will always want you to put the largest cannula possible. My strategy is a little bit different. I want to put the smallest cannula possible that will give you adequate perfusion. So it's a little bit different mindset, but it's important because I also think that if you put too large of a cannula, you can obstruct that flow to the leg, and sometimes you can end up with limb ischemia. I do not use a distal limb perfusion cannula for my minimally invasive cases. What about exposure? So again, we talked about incision location a little bit. That's my incision location, and the incision size is roughly 4 centimeters or so, give or take. I will cut down right above the rib, and I will divide the REMA, the right internal mammary artery, as well as the vein. I have to admit, I do a lot of bilateral mammaries here, but I've never needed to do bilateral mammaries on a patient with a prior AVR. It just doesn't happen. I'd love to get the input from our other panelists as well. So I don't think it's consequential at all to divide that REMA or the vein. I will shingle the rib. Some people don't, but I feel like it gives me a little bit better exposure. At least gives me some peace of mind for better exposure. And you'll see a little bit that ultimately you get really excellent exposure of the valve. Sometimes there's a big layer of pericardial fat. I'll just be patient. I'll just take off that fat, kind of really expose the pericardium. And I feel like the best place to enter the pericardium is right at that junction right there between the aorta and the right atrium. There's usually that space. So I just kind of grab the pericardium, I pull it towards me, and I just kind of bovie through, and I'll expose almost all the way down to the diaphragm south. Well, what's a little bit different about minimally invasive approach is my pericardial retraction surgeries. I'm very aggressive, as you see here. I've pulled the aorta towards me, probably more so than open procedures. You know, I'm really using those pericardial retraction surgeries to kind of drag everything into view. Here you see me kind of creating a plane above the right PA for the cross clamp. I'll place a line for the CO2, as you can see here, and then I'll connect CO2 to kind of flood the field kind of sooner than later. I will here, you see me placing sutures around the right superior pulmonary vein where I'll put a vent in. It's actually staring at you. It's actually not hard to do at all. I've never had any issues accessing right superior pulmonary vein and placing the LV vent. And of note, you'll see in a little bit, this is my primary way of de-airing. I don't have any aortic root vent, so I'll de-air through the right superior pulmonary vein. I'll place a cross clamp, pressure down, flow down, drag the aorta down, put that clamp as high as possible. I'll give antegrade and I'll take that needle out and I'll make my aortotomy exactly where I put that antegrade needle, just to get everything out of the field, because I know I can finish this operation usually within 60 minutes and not need to redose since I'm using del needle cardioplegia. Again, I'll have some retraction sutures, and there you have it. You know, you have a very direct en-face view of the aortic valve, as you can see here, and this is really just a regular standard surgical aortic valve replacement. So, so I think once you get those steps in place, it's very straightforward. I want to comment on my antegrade needle a little bit. You know, I'm always trying to be mindful of costs, and I use a very poor man's antegrade needle. I use a 14 gauge angio cath with a little kind of red rubber, the tip of it. That's all I need, and that's enough, and it kind of saves us some money without putting an expensive angio-grade needle in. Cardioplegia strategy, I use del needle. I redose 90 to 100 minutes, but it's rare that we have to really go more than that. Initial cases to avoid patients with AI. That sounds pretty obvious. Changing gears a little bit, this is a second scenario. A 60-year-old obese man with newly diagnosed AS and an LVOT of 19. This patient is a little bit different, is that he's obese. You want to make sure you put the largest valve possible, and he has a small left ventricular outflow tract. So in this patient, my plan was to do aortic valve AVR with a root enlargement. I'll usually do this with a sternotomy, just kind of get full exposure. And I wanted to walk through a little bit briefly some pearls and pitfalls of root enlargements techniques. This is a slide presentation by my good friend Vince Gaudiani, and I'll kind of go through it quickly. So you do your aortotomy, as you can see here. My approach is to eventually cut down between the left and the non-commissure, and then the key thing is to cut down almost across the mitral annulus. And I think it's really, really important to kind of go deep down as possible. When you're cutting down, be cognizant that you might, the left atrial dome is right behind there. So you gotta be really careful not to get into that. I put my retraction sutures, I'll size the valve, and here we'll see that, hey, that valve's gonna be too small. So I'm dissecting a little bit and cutting down further, as you can see here, to really kind of open up that annulus and open up and make that annulus larger. Again, being very careful to avoid the left atrium, as you can see here. I apologize that the video is a little bit not very clear. So as you can see here, we've cut down between the left and the non as deep as possible, almost to the mitral valve, making sure you expand that aortic annulus. And then next, I want to talk about the graft. I usually use a HemoShield graft, maybe usually a 32 or 33 or so. And the key thing, I think, is to make this graft as big as possible, because if you make a small graft, you're not going to enlarge the annulus at all. So usually when I do it, it's about half the size of the graft. You'll see it's actually pretty big. I'll cut it so that the black line of the graft is on one side of it, and I'll use that as kind of a marking point when I actually implant the patch, as you can see here. So from here, it's actually pretty straightforward. It'll be 3 backhand sutures on the graft, and then 3 backhand into the aortic annulus, and the rest will be a series of forehands, and it's actually a pretty easy operation. So I'll start my first backhand on the right side of that black line, and then I'll put it into the annulus on the right side of the division of where I divided the aortic annulus. The next one will be in the middle of the black line, and then right at the apex of the division of the aortic annulus. And the second one will be to the left of the back line, and then to the left of that annulus. And then from here, it's a series of forehand, all the way up to the aortic annulus. As you can see, I'm just kind of marching my way up here. And it's actually pretty easy, pretty quick operation. I think one of the things is that a lot of people talk about aortic root enlargements, but it's not commonly done. I think the way to do it is we just need to start doing more of it. But even patients, the more you practice at it, and even if it's a smaller aortic root enlargement, the more you practice and do it, you'll be very comfortable with being more aggressive and enlarging that aortic annulus. So again, here a series of forehand, and then bring it up as high as possible, and then take that tail on the other side. And then again, it's a series of forehand. And one thing I want to pause right there, see that where the forceps are, that's the size that we have just enlarged the aortic annulus. You want to see that triangle there to show that you've really enlarged the annulus. Otherwise, you're not really enlarging the annulus at all. You're kind of fooling yourself a little bit. So we want to see that size there. And then last kind of technical pearls is that you put your annulus sutures the same, but when you put your annulus sutures on the patch, you want to make sure that the pledge of the sutures are on the outside of the patch for reinforcement. So again, I want to thank you for just kind of hearing my perspective on kind of how to approach these complicated patients and providing some technical pearls. I want to change gears a little bit and segue into my good friend, Dr. Doug Johnson. Unfortunately, he couldn't make it today, but he wanted to give a presentation on the Cleveland Clinic experience with AVRs and the use of tissue valves. So we'll switch to Dr. Johnson.
Thank you, Tom, for setting the stage with a great case and a very expert illustration of how to do both a mini thoracotomy and a root enlargement when that's necessary. You gave a great introduction to tissue versus mechanical valves. I'd like to take us a little deeper into the landscape of tissue valves, talk about our current approach based on the data for the Inspirus Resilia valve, and talk about some studies that are ongoing that are important for our viewers to know about. I want to thank all of you for joining us for this webinar and thank Edwards for this opportunity. So these are my disclosures. The population of patients we're really talking about for modern surgical aortic valve replacement, at least for isolated valve disease, is the bicuspid population. This is a lot of people in the United States. So 1 to 2% of the population. There are at least 5 million bicuspid valves out there, and of those, at least 300,000 will need surgery within 10 years for valvular aneurysm. So it's a large number of patients, and these are still firmly in the SAVR realm. Many of these are young, and we have a lot of years to think about outcomes. When we look back at our experience with valve surgery at the Cleveland Clinic, we've recently had the chance to review our data back to the first implant in the early 60s. And you can see here that the choice of valve, and if we looked within bioprostheses, the choice of bioprosthesis has varied as new technology becomes available. And as TAVR becomes a dominant force in our choice of therapies, what valve we choose, whether explanting a TAVR or planning for a future TAVR, is a very important one. As technology evolves, we need to evolve with it. It's often thought that the evolution of aortic valves is sort of this inexorable progression toward the latest TAVRs, but we really need to keep in mind that in each of these categories of valves, technology is evolving. The Onyx valve is currently in trials with the PROACT 10A trial looking at apixaban versus Coumadin. We have a tremendous evolution in stented tissue valves in addition to TAVR. But if we look at the valve for which we have the most experience, both here at the Cleveland Clinic and worldwide, with the longest durability, it's really the perimount valve, which is the forerunner to the Inspirus Resilia that we're talking about today. This is a study that our group published back in 2015, is now being updated. But looking at the durability of this valve in real patients according to age and other parameters. And if you look on the left, what's remarkable about this earlier generation valve is that the actual risk of explant, even for young patients, 40 to 50 years of age, was only about 10 to 11% at 20 years. The actuarial risk shown on the right side, again, very, very good for patients who are 60 to 80 years of age. But in that less than 60 population, we know that valve-related durability is really an important outcome. It's a very good valve, but between 8 and 15 years is really when we're seeing these explants start to rise. Even though a number of patients do make it to 20 years, the risk of explant we might consider is moderate. This is good data to be able to tell a young patient regarding their durability, but we can always look to do better. As we know, the explant risk for patients who are older is very low, but it's the less than 60 group that we really care about. Why does this matter? Why are we talking today about valve choice if the ultimate downstream second intervention is going to be a valve-in-valve TAVR? Well, when that happens and how efficient that second valve is a very important consideration. And we know that valve choice matters. It's not only the hemodynamics at implant, the reasons to consider a root enlargement, but it is the durability of that prosthesis. And we recently had the chance to review the outcomes of the trifecta valve versus the CE in a study that was led by one of our medical students. Trifecta was known for excellent hemodynamics at implant. And we can see on the left side that the gradients at implant are quite low, even in small valve sizes, as we found for the trifecta valve, lower than the CE. But unlike the CE or perimount valve, the hemodynamics for the perimount here in blue are very stable, whereas trifecta gradients started to rise early after surgery. And we saw a crossing of those lines by 4 years. And this is borne out in a prevalence of severe AI as well, quite low for the CE and starting to rise by 5 years for the trifecta. The result of this is that there is a small, granted these data are 5 years, but real difference in the risk of explant between these two valves. And we expect this to continue, this trend to continue in a very meaningful way. If we can see a difference in explant at 5 years, we need to be very careful about using a particular prosthesis in younger patients. What was interesting about this study is, surprisingly, the primary mode of failure was calcification rather than leaflet tears, as we might expect for an externally wrapped valve. Why are we talking about RESILIA? So RESILIA is the tissue treatment. The Inspiris valve is a natural iteration of the technology that began with the perimount, which we showed the data for a little while ago. The general design of the valve is very similar. There have been iterative improvements, including the VFit technology, which is designed to allow future TAVR valve-in-valve, which we'll talk about in a moment. This valve was demonstrated in patients in an early European feasibility study, 133 patients, which is the earliest data we have in humans on the perimount, showed stable hemodynamics and no events of structural valve deterioration. The follow-up to this really was the COMMENCE trial, of which we were a participating site. This was a large multi-center study in a real-world population of patients. You can see mostly symptomatic, wide variety of ages. The mean age was 66, so a little younger than most of the TAVR trials, and a very real-world population, including the STS risk. The valve size distribution reflects, I think, modern practice for most of these valves, very few 19s, a lot of 21 through 25s. The most important safety endpoint, of course, that we care about that is related to the actual prosthesis is structural valve deterioration. And there were no cases at 5 years of structural valve deterioration. There are some other things that we might be concerned about based on the trifecta data with any new valve. And we think about things like thrombosis, of which there were no events. More mild versions of thrombosis might show up as early transvalvular regurgitation or a change in valve gradients. So while there was no structural valve deterioration, most of the events were endocarditis. We see here that the hemodynamic performance is very stable, where the gradients to 5 years are really minimally different for all valve sizes. The orifice areas, as we would expect, calculated from that, are stable. Paravalvular leak, which is really mostly a patient and technique related outcome, but also related to the sewing cuff, very uncommon. But importantly, for that consideration of the tissue itself, is that transvalvular regurgitation was very uncommon. So this gives us confidence, at least to 5 years, which is again where we saw an outcomes difference with the trifecta, that the Inspiris RESILIA valve is not subject to unexpected problems in human implants. So When we think about durability in younger patients, what we really want to look at is the 7, 9, and 10 and further year data. The resilience trial is a longer term follow-up study looking not only at valve-related reintervention or death, but at hemodynamics, which is very important. So this will be adjudicated by echo and multi-detector CT. So these secondary outcomes, which we know are earlier findings than explant in many patients, are very important. We're going to look at valve leaflet calcium and hemodynamic structural valve deterioration in the resilience trial. Another study, which is a very large European registry study led by Bart Muris, our colleague in Leuven, is the Endure Registry. This is a durability study looking at patients under the age of 60, so the population that we're very concerned about for more earlier structural valve deterioration for which the Inspiris may be a beneficial valve. This will look at clinical and echo endpoints at 5 years. And the Impact Registry is a subgroup analysis by comorbidities looking at clinical and echo endpoints at 1, 3, and 5 years. So these are registries which are enrolling, and we look forward to the data from both of these studies. Looking at an endpoint that we, of course, are concerned about with a valve that's designed to allow for valve-in-valve TAVR, the Invivity study, of which I'm the national PI, is designed to capture adverse event information and valve measurement data when we get to the point of doing valve-in-valve implants in the Inspiris valve. The goal is to enroll 50 subjects at 10 sites. Obviously, with the durability of this valve in the early studies, we don't expect that we'll have a lot of enrollment for a while in Invivity, but this is an important study which will tell us about how effective an intervention valve-in-valve is for the Inspiris valve. The important aspects of this are that, of course, cardiac CT is going to be used to collect dimensional data for the Inspiris valve for valve-in-valve. So to bring this back to the clinical real-world experience we care about, this is a study that we currently have in press in JTCVS, which was presented at the AATS 2 years ago, looking at how the practice of isolated valve surgery has changed. This is in the pre-low-risk TAVR era, but on the left side, we see the STS expected risk of morbidity and mortality, and on the green line is the observed. This is obviously a learned experience over many years at our institution, essentially reflected by other centers of excellence, by surgeons like Dr. Nguyen and others, that the real outcomes in the hands of an experienced center for isolated SAVR are excellent. And this is reflected in the right side of the graph, showing that long-term survival was actually better than age-matched controls from the US Census. As these valves get better and better, I think this gives us confidence that putting a durable tissue valve in a young patient is a very reasonable intervention, and it gets more reasonable as the valves get more durable and our ability to do safe operations gets better. And to the extreme of durability, this is a recent study from JTCVS Open looking at very long-term in vitro durability of the Inspiris valve. This is a 1 billion cycle study, which is truly remarkable durability in vitro. And if you look here on the left-hand side, not to get too in the weeds with the hemodynamics, but what's remarkable is the laminar flow is preserved at the billionth cycle. So this is a valve that is opening and closing similar to the day that it was put in the pulse duplicator, equivalent of 25 years later. Our Cleveland Clinic Inspiris experience continues to evolve. We're over 2,000 implants for the Inspiris valve and 189 for the Connect. Stay tuned as we get longer term data. Single center registries are also going to be very important in our understanding of the real world function of this valve. So in summary, we know that long-term survival in low-risk TAVR is similar to the general population. If we can avoid the calcification, which is the most common form of SVD, with a valve that we know is durable in vitro and has shown very good promise in vivo in the COMMENCE data, will be followed up with the 10-year data, but I think we are increasingly confident that this valve represents a new generation in the treatment of younger, lower-risk patients. Thank you very much for your attention, and look forward to my colleagues' discussion, which I'll have to enjoy remotely.
Thank you, Doug, as always, for offering your expertise and the perspective from the Cleveland Clinic. I think, as we talk about quality and approach, it's almost always important to think about costs and health economics, which is a segue into the next talk, the health economics data for Inspiris Resilia aortic valve by Dr. Bart Murris. Bart, it's all yours.
Okay, thank you, Tom, for this nice introduction and great moderation. Thanks to Edwards for organizing and making this kind of webinars global feasible. And we have been talking about some new and interesting technology, but as we all know very well, this kind of innovations come at a price. And so it's always reasonable to think about some cost issues as well. Now, in my talk, I'm not going to talk about the comparison or the evolution in TAVR technology, but for the moment, if we are focusing on AVR in the younger patients, bicuspid patients, and so on, there's the competition with mechanical valve use. And this is a slide showing the percentage of mechanical valve use. This was a very recent data published now 2 years ago, and this is data coming from North America. And you can see clearly the decrease in the overall use, even in the younger patients below 65. Back in 2004, we were still using over 60% of mechanical valves in these kind of patients, and now it's below 20%. So the mechanical valves are really decreasing. And Tom, you have really highlighted the three main reasons, the three main drivers behind this: Coumadin, the potential use for having TAVR down the line, etc. So these are the drivers for the decrease in mechanical valves. And this is happening, I think, across the globe. On the left side here, you see data coming from Germany, with in blue colors here, the lower use of mechanical valves to below 10%. And this is our own data with, again, in blue, the mechanical valve use going down year by year, even in younger patients. Now, of course, we have to realize that if we are using tissue valves, and of course, this is also valid for TAVR, I mean, if you use more and more tissue valves in younger patients, there is still the risk of having calcification and degeneration on the long run. And there are even some unresolved issues, even in tissue valves, with pannus formation or early thrombotic reaction occurring on the top of tissue valves. So this is why we need innovation. And it is thanks to the industry, I have to say. It's thanks to valve manufacturers like Edwards, for example, who keep on investing and keep on pushing forward towards having better durability, better longevity of the tissues they are producing in their valves. Resilia is a great example, and I think it's the best example of the most advanced tissue technology that we have out there now. And we did here in Leuven, we did the whole preclinical evaluation for Resilia tissue back already in 2010. We published this in JTCVS in 2015. And we were comparing the Resilia tissue versus the golden standard at that time, which was the Perimount technology. And it was quite easy to see that the Resilia really has a lower calcification in the preclinical animal model. And we really hope, and we have good clinical signs, that this will turn out to be true in the clinical practice as well. There was a second observation, and this we published only recently, that next to the lower calcification in Resilia tissue, there was also less pannus formation. And I know there is less interest from the surgical side towards pannus formation on top of tissue valves. But this is an observation that we made, that Resilia, compared to the Perimount technology, really produces less pannus and less kind of these reactions on top of the tissue. So this is another example that Resilia is not just some kind of new tissue treatment, but that we are really talking about a new tissue technology with a different host to tissue interaction after the implantation. And I think Doug Johnston in his talk clearly showed that there is a huge effort now globally ongoing in showing the clinical value and the real clinical representation of this new tissue technology in the clinical field. We have 2 large European and North American trials with the Resilia tissue ongoing. There is a resilience trial that will focus really on calcification in the younger patients in the long run, up to 11 years after the operation. And we have registries like Endure and Impact, who will focus on the effect and the real performance of Inspiris Resilia in the young patients. For example, in Endure, I can tell you that all the inclusions have been made successfully. There's more than 400 patients involved, and the mean age is 53 years old. So this is really the first time ever that we are introducing a tissue valve in such a young population, and we will learn and see how the performance is going there. But of course, with this new kind of tissue innovation, we are taking away the place of the mechanical valve. And so we end up in this discussion, okay, in these young patients, what are we doing? Are we still using mechanical valves? Are we going to these new tissue treatments? And I don't want to end up in the whole discussion of mechanical versus tissue, because this is a whole symposium in itself, but I want to focus on the cost aspect, because, you know, I often get the comment, yeah, these new tissue valves, they are more expensive and they have to pay more. There's of course a cost attached to this new kind of evolution and this new kind of treatments. But it's interesting to see, whenever you look at all studies, and these are two examples of two large North American trials comparing mechanical valves to tissue valves in young patients, and you always have a difference in hospital stay. The tissue valves, and this is of course because of the fact that you don't need to start anticoagulation, you don't need to start warfarin or Coumadin treatment in these patients. You're able to discharge these patients a day or two earlier, and of course this will immediately translate into a cost saving issue. This kind of observation has triggered us here in Belgium, in my center, to do a propensity matched comparison between mechanical valve use and Inspiris Resilia use in really a young patient cohort. What we did is we looked in retrospect to the last 5 years of our experience, and we collected our patients really between 40 and 65, so a really young adult patient population. And we looked at what we have done in the meantime. We have 95 Inspiris Resilia cases. We have 69 mechanical valve cases in that period of time. And we were looked at a length of hospital stay, and we estimated the cost. And we also looked what happened in the first year of follow-up. Of course, when you do this direct one-to-one comparison in these two retrospective cohorts, there's always slight differences. There's a difference in age or in Euroscore profile. So we did propensity matching to have a nicely 40 pairs of patients who were perfectly matched with no difference anymore between these two patient groups in a large set of preoperative variables. And this gives us the possibility to do a fair comparison of the early performance of Inspiris Resilia versus mechanical valves, and to look at cost issues as well. Well, in this 40 pairs of patients propensity matched, it was very easy to see, and it was a very clear and clean observation that the Inspiris Resilia patients were able to leave the hospital significantly shorter than mechanical valves, and we can easily have a reduction of hospital stay of 2 days, which of course translate into a cost-saving issue, a cost-saving effect right away. Of course, this is related, as I mentioned, to the absence of anticoagulation treatment. And I know we are talking for a global audience for the moment, and I don't know what all the centers are doing, and the world is still divided in having early anticoagulation in tissue valves, yes or no, but I can speak from my own center. We don't anticoagulate tissue valves if these patients are in sinus rhythm, and this gives you the opportunity to this early discharge and this really reduction in hospital stay by using tissue technology in these younger patients. Due to the shorter length of stay, you can easily save up to €2,000. These are prices valid for Belgium, for my center. 1 year, if you look at what is happening at the first year of follow-up, then we can estimate 1 year of anticoagulation costs us approximately 800 to approximately €1,000 of cost that you need to do in the mechanical valves patients, which is not present in the Inspiris Resilia, in the tissue valve patients. So easily, even without any complications occurring, you have a reduction of approximately €3,000 by using this tissue technology in young patients. And then when you look what is happening during the first year of follow-up, of course, in the Inspiris Resilia patients, there's not much happening. We have 2 patients with a minor TIA. We have 1 with a pericardial effusion. But when you look and this is often forgotten by surgeons. In mechanical valve patients, you can have some issues. You can have, there's one patient in this propensity matched comparison, one patient with an ischemic stroke. There's one patient with an acute myocardial infarction early after the operation, also thrombotic in origin. And of course, these kind of early complications, they have a tremendous cost. And then when you put them into the equation, then of course the whole cost comparison is completely disadvantaged for the mechanical valve patients, and you can save a lot of money by using tissue technology in these kind of young patients. Of course, we already know that if you are able to avoid anticoagulation, that this relates into a cost reduction, because we know this from, for example, the studies comparing the warfarin treatment versus the NOACs, the new anticoagulants. For example, in venous thrombosis, this is a large study showing that you can easily save up to $2,000 in just avoiding the anticoagulation start in patients needing some kind of anticoagulation therapy. And it is not only the anticoagulation start that can save you money, also the longer follow-up, chronic warfarin treatment also comes at a price. This is a large, again, North American trial comparing warfarin to apixaban, one of the new anticoagulant drugs here in atrial fibrillation treatment. And again, you will save money by not having patients on warfarin, by not having patients on Coumadin, but by using, completely avoiding the long-term warfarin treatment. So in conclusion, we are living in a tissue valve era. I mean, this movement away from the mechanical valve was already ongoing before the advent of Inspiris Resilia. But of course, the advent and the introduction in clinical practice of these new tissue technologies have only accelerated the use of tissue valves in younger patients, and we see less and less mechanical valves. The cost issue that is related to that really is in my mind not really an issue, because if you compare in use of tissue valves versus mechanical valves in younger patients, we see actually a cost reduction by avoiding and by the absence of the anticoagulation therapy, the start of anticoagulation, and all the costs and complications related to long-term anticoagulation in the long run. Of course, the long-term result of Inspiris Resilia is still a sort of question mark, but I think both Doug and I showed you that there is a large effort ongoing for the moment in several ongoing clinical trials and a lot of large-scale registries in young patients to see how this new tissue technology will turn out in the clinical practice. I thank you very much for your attention, and I look forward to the further discussion. Thank you.
Thank you, Dr. Meuris, for an excellent presentation. You know, I think the most exciting parts of these webinars is really the discussion, and we're excited to answer a lot of the questions that were presented in the chat box. And I encourage all of you to continue to submit any questions that you'd like for us to answer. I just want to start off. I think we're really at an exciting time in the treatment of surgical aortic valve disease, because for the first time in a long time, we're seeing a lot of advances in technology, and we've seen some rapid advances in the transcatheter space, but we are seeing finally some advances in the surgical aortic valve technologies. I want to present the first question that has come up and come to mind. You know, Bart, you said that we're living in a tissue valve era, and we've kind of talked. One of the reasons why is because we don't like Coumadin. But let's say right now, as you know, there are mechanical valves out there with an INR target of 1.5 for the aortic valve. You know, let's say if you came up with a mechanical valve with an INR target of 1 or of no Coumadin, you know, do you think we'll still live in a tissue valve era? I'd love to get your thoughts, and then Ed Soltesz, if you can kind of chime in as well and kind of give us your perspective as well. If we're leaning towards tissue because of Coumadin and the INR issue, and maybe if we had a mechanical valve that didn't have that INR issue, if things would change.
Well, I'm going to give you a short answer, and then I give the floor to Edward. I mean, I think the low INR regime has been out there quite some time. No, I mean, the Onyx trials have been done quite some years ago. And I think it's still Coumadin, it's still warfarin. And this is the whole Achilles heel of the mechanical valves that we have. And to be honest, for the moment, we don't have a mechanical valve design that is completely free of Coumadin. And we still don't have any perfect alternative. I know there are trials ongoing, and I know there is also preclinical work with experimental valves, but we are not there yet. So for the moment, this whole tissue valve preference is still very much alive. And to be honest, it's an interesting time to live in now, because in the next few years, we will see how the long-term follow-up of all these tissue valves will turn out for many patients.
Thank you, Bart. Ed, what are your thoughts?
Yeah, no, I sort of agree with exactly what Bart just said, and that is to say we don't have that technology yet. The technology that we have still is the mechanical valves that are in existence today, and that we're trying to understand what that target INR is. And regardless, there's still the hazard of getting some form of thrombus, some increased risk of thromboembolic disease with the lower INR. We just have to define what that is. But unfortunately, that is still, no matter what the threshold is, you say it's 1.2, it's 1.4. Of course, when people take Coumadin, it's never always just 1.2 or 1.4, right? It varies. I mean, we've all had patients who get admitted with the need for Coumadin therapy for whatever purpose, whether it be a mechanical valve or atrial fibrillation or an LVAD, for instance, where their INR is 7 and all the risks inherent with that. So no matter what, I think we still have to come back to the fact that the technology with mechanical valves is not there yet. And will it ever be there? I don't know. I don't know if we're ever going to find a surface that's going to be completely thrombogenic, not thrombogenic.
Real quick, since we're talking about anticoagulation, what's your anticoagulation strategy for a tissue valve? Just kind of one or two sentences. What's your approach, Bart and Ed? Aspirin Plavix or Coumadin?
For us, a tissue valve in sinus rhythm is aspirin only.
Ed?
Yeah, we do the same, just aspirin.
Perfect. Interesting. I do aspirin Plavix. I'm not sure why. There's no real data, but it just gives me, a little more peace of mind. The first question is by Hafil Abdulghani, and he brings up an interesting question about whether or not similar results in the pulmonary artery position, and I assume he's referring to the Ross, and that's something we haven't discussed too much. Ed, if you could start, what's the role of Ross procedure in patients who are younger patients with aortic valve disease? And then Bart, I'd love to get your thoughts as well.
Well, the Ross procedure obviously is something that we have been exploring. I think a lot of places have been exploring. We typically reserve it for very young patients. And what's very young, I would say, in the teens, 20s, maybe early 30s. There is, of course, the hazard of the pulmonary valve and the complications that result from that, and the sort of unknown durability in various different cohorts. And again, it's an area where I think everyone's starting to understand. We have done reverse Rosses. So we have gone in and taken the Ross out, put it back where it belongs, so to speak. And it still functions very nicely, even if it's dilated slightly in the aortic position. Put it back in the pulmonary position and done a biologic valve conduit, for instance. So, and typically those are large annuluses. So we've done a fair bit of those. So I think again, it's reserved for very unique situations.
Thank you, Ed. Bart?
Yeah, I mean, the Ross operation is interesting because I have two of my colleagues who really are focused on that, and we like to extend the indication for us up to the age of, let's say, 50 to 55. So if you really have a 40, 45 or 50-year-old patient in excellent condition, we do offer the possibility of Ross. And I think there is more recent data with promising results, but we have to be honest, the really, really long-term result, 15, 20, 25 years, even in these patients, is uncertain. And of course, if they come back for redo, they can be challenging situations there, and you can have double valve disease because there's the pulmonary also involved. So we do offer it. but it's a question mark on the really long run, I have to be honest.
And my thoughts is that I think there's potential for ROS, but the ROS procedure is only done by a small handful of surgeons across the globe. It's technically more challenging, and the best solution is something that we can address that every surgeon can do safely and relatively effectively. Alabeg has two interesting questions. He wanted to present a scenario of a patient that's 40 to 50 years old, tissue versus mechanical. Ed and Bart, and I assume with that progression, if you do tissue, the idea is tissue, and then later on, valve and valve, or versus versus mechanical and being on Coumadin the rest of your life. So thoughts? Ed, maybe you can go first.
Yeah, so I think the first thing we know is even in young patients, we've got the data from Mark Rule's paper many years ago, looking back at a Canadian population where there, even in younger patients that young, there was no survival advantage to placing a mechanical valve. There's some data that's come out showing some differences, but in fact, if you look very carefully at the papers, you'll see that there's either bias present or it's incorrect propensity matching. So number one, there's no difference. The second is back in the year 2000, between 2000 and 2004, the independent risk of a reoperation disappeared in almost all cardiac surgery databases, and especially for aortic valve reoperation. So I think that the hazard for reoperating, even if you say reoperation, is really not a concern. Obviously, patients get older and their risk factors build up, and so the risk, the actual risk is slightly higher with the reoperation, but that's not an independent risk factor of the reoperation itself. The other point I would make is that with the way we had seen Tom do the right anterior thoracotomy AVR, or even if you do an upper hemisternotomy AVR, sort of a minimally invasive approach, we have data to suggest that that makes the reoperation all that much easier, less blood utilization, less time in the hospital, so on and so forth. So I think even when you take someone who's 40 to 50 years old, I think it's still tissue valve is still paramount. And looking back at the data that Tom initially had showed, as well as Doug had put on his talk, I think it's important to understand the difference between the risk from a patient's perspective as to what is their risk of needing a reoperation versus the Kaplan-Meier estimate, because both of those are different ways of looking at the risk, right?
Thank you. Ed, Bart, anything else to add?
Well, yeah, of course, this is the most difficult or challenging patient population that we are facing now, because you mentioned correctly, 40 to 50, okay, ROS may be an option, but only in selected centers. So it's a minority of the world. Secondly, mechanical valve, yes, but you have lifelong Coumadin and all the problems related to that. And also we have to remember, also the mechanical valve is not free from reoperation due to pons ingrowth and so on the long run. So you have also these difficulties. So yes, I think with the advent of these new tissue technologies, the tissue valve in this age category is an option. But then your presentation, Tom, comes into importance, because you have to take into equation, one, minimal invasive surgery, and secondly, putting a large, decently sized valve in there, because a large valve will increase the chance of having long-term durability and will have more chances of success of having a good transcatheter valve-in-valve treatment 10 years, 15 years, or maybe even 20 years later. So these are all important elements to take into the equation when dealing with such young patients.
Thank you. That segues into another question by Alabeg. What's a minimum size RESILIA valve to give the patient an opportunity to benefit from the future valve-in-valve? So what's the smallest size tissue valve that we should tolerate? Bart and then Ed.
For me, I mean, the 19 millimeter is a thing I of course I try to avoid as much as possible. But we didn't mention this in this symposium today, but the Inspiris RESILIA is not only an innovation in the tissue science, but there is also this expandable frame, and this is for the first time that the valve frame is designed to open up with an increase of at least 2 millimeters of internal diameter. Of course, this is only bench science for the moment. There's no clinical data yet to explore this, but yes, a 19 millimeter should allow for, let's say, having a 23 millimeter transcatheter valve put in later on down the line. But this is still a theory for the moment. There is no clinical data and evidence yet.
Thank you, Ed.
You know, I agree. I mean, always try to place a 23 or larger valve. We know from data longstanding now that once you have older patients, the valve size does not impact patient prosthesis mismatch in terms of survival, or nor does it impact incidence of SVD. But in younger patients, it does. So we're very aggressive with root enlargement. I do mine exactly the way Tom showed, except I use bovine pericardium. I don't think there's a difference. And it really only adds about 5 to 10 minutes to the case. It's actually very, very quick. So, you know, I will say that if you've not enlarged a root, that really does not increase the hazard of the operation, does not increase the risk of the operation. But as Bart had pointed out and Tom had pointed out, you know, when you looking at something like a Ross, that's a big deal. That is a significant increase in risk, and really something that has to be appreciated. It's really hard to generalize that to the you know, every surgeon across the globe.
Thank you, Ed. We have about 4 or 3 minutes left in the presentation in the webinar, and I want to try to get to 2 other important questions. Again, I feel like a lot of times we should reserve maybe 40 minutes to question and answer, and maybe 10 minutes of a presentation. My good friend Patrick Meyer, essentially, I'll summarize his question, and he essentially shows that there is some pretty good data out there showing a survival benefit in patients with mechanical valves, particularly in younger patients. So with this increasing interest in bioprosthetic valves and much resources being poured into studying using these valves in younger patients, how are we going to accrue the data, either prospective or randomized, needed to tease this out definitively? And I'll have you start, because I know that Cleveland Clinic has been pretty active in trying to answer this question. Then Bart, you can answer as well.
Yeah, I think the problem is going to be that the only way to accomplish this would be through a randomized trial. Randomized trial in that patient population. We have to have equipoise to obviously enroll patients in that trial. I think some of the data that, you know, there was a New England Journal of Medicine paper that came out from Joe Wu, and looking at some California patients. Again, you know, it's not generalizable, and there's implicit bias present. Obviously, when you take younger patients, there's an implicit bias to put in mechanical valves. And it is possible, very possible, that if you have someone who is getting a tissue valve in their mid-40s, 10 years ago, for instance, there was a reason why that you were not able to capture in the standard comorbidity profile that you're able to gather, especially if it's claims data. So I think that, unfortunately, no matter how you look at propensity matching, there is bias present, because we don't have equipoise in that area. So we're going to need a randomized trial. Are we ever going to get a randomized trial? I highly doubt it. Highly doubt it. So I don't know the answer, you know, to your question, but I suspect it's going to be an ongoing issue.
Bart, what are your thoughts?
With all due respect to these large papers, and I know what you are talking about, but these are long-term follow-up papers, and you know, this is looking at the past. This is looking at implants that have been done in the 80s, 90s. So with older tissue valve types, we didn't have the availability of the newer tissue valve types. We didn't have a lot of availability of doing TAVR valve-in-valve treatment. And like Ed has mentioned correctly, there will be bias in patient selection present there. So this can explain this survival difference observation, I think. So I want to challenge those studies a little bit, because it's looking at really a look into in the past and not into current clinical practice.
We have about maybe 1 minute left. My last question is a question that's come up a couple of times in the chat box: the Ozaki procedure, as many of you know. So what are your thoughts about the Ozaki procedure in young patients needing aortic valve replacements? Do you do it? What's the future of the Ozaki procedure? And we'll wrap up after this.
For me, I can start maybe.
Or Bart, go ahead.
Ozaki did his PhD thesis at my institution. Is a good personal friend of me. And we have some Ozakis in follow-up, but I think the Achilles heel is the material that we are using. I mean, the autologous pericardium, to be honest, certainly in the younger patients is not going to help us out. I think it can be challenging also to do TAVR treatment in these large, high coaptation height cusps. And so, to be honest, I'm a bit afraid for the long-term durability.
Ed, you guys do
Yeah, Bart,
Ozaki at the Cleveland
We
Clinic?
do quite a few Ozakis, and again, we have to wait till the long-term data. It's going to take a long time to get that data. It does create some issues. Obviously, as using autologous pericardium, we don't have the ability in the operating room right there to check the thickness, uniform thickness of the pericardium, and so on and so forth. That's available in creating tissue valves in the factory. Obviously, it's a different, it's an autologous pericardium, but I think that unfortunately, it's just going to take time. Time's going to tell. But you always have to remember, I think, as you bring on new technology, you don't want to burn bridges. You have to be very careful about that. And Bart's comment was very important, and that is, it's going to be challenging to do a valve-in-valve in these cases. So I think we're always looking for new opportunities, and as surgeons, we're always looking for neat and exciting new procedures that we can hang our hat on and potentially offer our patients. We just always have to be careful about the safety, not only at the time of the operation now, but look to the future and understand exactly what does it mean if we have a failure.
Thank you, Ed. Or I'll throw the last kind of comment, maybe try the Ozaki with the residual tissue as another kind of a permutation of something to look at. I just want to thank Bart, Ed, Doug for participating in this really important panel. From the discussion and the chat, there are clearly a lot of unanswered questions, but also a lot of enthusiasm about this field. We hope to try to address aortic valve disease, but also try to look into the future and look at the management of aortic valve disease, not only in the short term, but in the long term. And we try to answer some of those questions today. In the chat box, we have our email addresses. And again, there are so many questions out there. We welcome any of you, the participants and the attendees, to email us anytime, and we will do our best to answer your questions. Again, thank you for participating. I want to thank Edwards. I want to thank CTSNet for hosting this webinar. Please enjoy your day and look forward to seeing you all in person soon. Thank you, Ed. Thank you, Bart. Thank you, Doug.
No, thank you, Tom.
Thanks, guys. Bye-bye.
See you. Bye-bye.